Good afternoon. My name is Jim McKee, and it is really a pleasure to be with you this afternoon. I want to thank Frank for such a nice introduction this morning. We're going to have a really fun afternoon. We're going to look at a lot of different cases. I'm going to show you a picture first, though. It'll be a kind of an interesting introduction. If you take a look at the slide, you can see that's my wife, Lisa, and I. We both like to golf. And you might wonder, why would I put a golf slide up for an occlusion lecture? If you really think about it, it's kind of a similar thought process. When you stand up and tee a ball up, you're going to hit it, and you're hoping it goes down the middle. But sometimes it goes to the left, sometimes it goes to the right. You don't always get the outcome you're looking for. It's similar with occlusion. If you take a look at these splints, I did some of these splints. I thought they would work. We're going to look at the case later on this afternoon and tell you why they didn't work. But what it comes down to, ultimately, the common denominator between golf and occlusion is many times we're not confident in either one. So that's really the tie-in for that. So I think Frank talked about it a little bit this morning, and I think really the question is, why about occlusion? And for years, our thought process has been about occlusion. How do the teeth fit? If I ask a room full of dentists, describe occlusion to me, it's how the bite fits together. The problem is, when we look at the anatomy, that's not the real world. Because when we look at the anatomy, as Frank said, not only do we have to look at the teeth, but we also have to look how the right condyle fits against the right joint socket with the disc involved, and the same thing on the left side. So when we really think about occlusion, if we limit our thought process to teeth, which I did in the early years, and I'll share that with you, it leads to inconsistent results. So the part of the issue is looking at joints is we don't really have a realistic perspective of what joint anatomy looks like. Because if I asked each of you to draw what a joint looked like, probably what we'd see are pictures that look something like this. Because when we think about what a temporomandibular joint looks like, our mind goes back to what we learned in school. And if you look at the textbooks that we learned at, these are the images that we saw when we talked about structurally altered joints. The imaging that we're going to look at today is going to show you really different views of the joint. And most of the time, what we are is we're lulled into a false sense of security with the joints, because in our mind, when we think a patient has a clicking joint, we see something that looks like that. The images that I'm going to show you today, which are direct visualizations of the joint through MRI and CBCT, show us a very different joint, and therefore that's going to lead us to a very different thought process and discussion with our patients. So really, I think one of the things that we have to do is we have to get a little better foundation on what joints really look like. The other thing is, I don't think we really have a clear understanding the joint impacts occlusion. And I really thought Frank's ending before lunch tied perfectly into this, because when we take a look at how the joint impacts occlusion, then we can start to understand how the teeth fit together. Let's look at a case. We take a look at a case at George. George presents with an anterior open bite. What do you think George was diagnosed with? A tongue thrust, because typically that's what we thought caused bites to open. We thought that when he swallowed, he put his tongue in between his front teeth and the teeth separated. Now, when you take a look at the joints, we see something dramatically different. And when you take a look at the condyles, you can see basically there aren't any condyles in his case. When Frank talked about a loss of vertical dimension, this is at the end of a loss of vertical dimension. And what happens is, when we start to lose vertical dimension at the joint level, the teeth have really no option but to uncouple at the anterior segment. Now, if I told you he's 16 years old, all of a sudden now this case becomes a little more problematic, because someone at that age who has that amount of bone breakdown has a difficult prognosis ahead of him. But the other thing is, I think we underestimate the impacts of early joint injuries on the occlusion. So here he is, it's 14 years old, you can see the retrognathic mandible, and typically when I show the picture, the discussion is, well, he was born that way, it was genetics. But if you look back at serial photographs earlier in life, here he is at 3 years old. He had a chin at 3 years old. So something happened between 3 and 14 to cause him to have the retrognathic mandible, to cause him to have the joint-based malocclusion, to cause him to have airway problems. All those things start to pile up, and we see patients now that have issues their entire life in terms of pain, in terms of occlusion, in terms of aesthetics, in terms of airway. And really, if you take a look at this case, this started at the joint level sometime after 3 years of age. So I think those are the things that we have to start to get more comfortable with in terms of understanding occlusion. The other thing is we, as Frank said this morning, we have a more difficult time recognizing high-risk patients. Let's take a look at another case. This is Tracy. When you take a look at Tracy, her occlusion looks pretty good, doesn't it? She lines up pretty well. This is in maximum intercuspation. I'm going to show you another view that's going to be a diagnostic view for you that's going to give you a different insight into the case. Here she is in a fully seated joint position. You'll notice I said fully seated joint position instead of centric relation. Centric relation typically is what dentists do when the condyle's in a superior position in the joint socket. By definition, centric relation implies that there's a healthy condyle disc assembly. I've changed my verbiage over the years to a fully seated condylar position because I think that more accurately reflects a case like this with Tracy. Tracy was 34 years old. We just did a study club module on her, so if you're looking for a module in your study club on cases like this, this would be a good one to take a look at. But when we take a look at her in a fully seated condylar position, we see a radically different bite. And if you start to take a look at the midline on the lower compared to the upper. See how that shifted to the left? So all of a sudden now, I start to become a little suspicious of a loss of vertical dimension at the left joint. I'm going to show you her imaging, and what I'm going to do is I'm going to show you a CBCT. I'm going to show you a picture of her condyles from a coronal or a front view. I'm going to show you both of them on the same plane. When we take a look at the difference. That left joint didn't grow. You'll note the maxilla didn't grow either. Note the joint socket compared to the right side. We've always thought that joint problems impacted the mandible. They impact the maxilla as well. We'll look at some cases later on this afternoon that demonstrate that. So I think those are some of the issues in occlusion that we really need to think about today, because many times we're going to see these patients in our practice on a more frequent basis than we've been told in the past. I think there's more patients with joint-based injuries today that cause joint-based malocclusions, and by the fact that you're at Spear, you're probably going to attract a group of patients that are looking for more comprehensive treatment. That'd be the same whether you went to Coyce, whether you went to Pankey, whether you went to Dawson. Any teaching center that emphasizes a comprehensive level of examination, you're going to find more patients who have occlusally based problems. And many of those problems start at the joint. So my goal today is to get you confident and comfortable with joints, because I don't know about you, but coming out of school, I was not. I mean, I didn't have any background in this. My training in school was to tell patients not to chew gum and not to chew ice, and that was it. I mean, there was no diagnosis, there was no nothing. I want you to go home here today with the confidence that you can know when you need to start to get additional diagnostic information, because ultimately, if you can solve these patients' problems, they will find you. We'll talk about that at the end of the program today in terms of the practice management side. But really, I think those are the things that we have to talk about. Frank talked today about the 3 types of joints that we see commonly in clinical practice. Structurally intact, that means the disc is attached at the medial and lateral pole. Structurally altered at the lateral pole, think of that as a participated disc where there's a ligament tear at the lateral aspect, but the medial aspect is still intact. And then the third is structurally altered at the lateral pole and medial pole. In those cases, think of that as a complete disc herniation, and there's a ligament tear not only at the lateral pole, but at the medial pole as well. Now, in my practice, I do see joint patients, but primarily I'm a restorative dentist, much the same as everyone else in this room. And what I'm really looking for out of this information is, what is my risk profiling? So, as Frank talked about, patients who have intact joints have very low levels of risk. We can pretty much do anything and they'll be okay. Patients who have a partially herniated disc, the lateral pull click, many times that's the male that's had the click for 25 years and has never had a problem. Those are green-yellow cases, most of the time low levels of risk. The slide on the right, though, are the ones that are the tough cases. Those are the yellow-red cases. Those are the patients that tend to have a more difficult time getting their teeth to fit together. Those are the ones that many times present with more pain. Those are many times the ones that present with airway problems, because as we lose vertical dimension, ultimately we collapse the airway. I'll show you some images today that'll really show that in terms of tying joints and airway together. So those are the three types of joints that we see typically in practice. What I want to do is I want to start out and talk about what's the anatomy for each of those. What's the patient going to tell you if they come in with each of those types of joints? And what's our thought process as a dentist on those types of joints? So let's start with structurally intact. I'm going to show you a video of a cadaver specimen that was done by Dr. Westison that really is an interesting thing to look at. We're going to look at 4 different videos throughout the afternoon here. And as you take a look at this video, what I want you to do is I want you to take a look at the size of the disc. And I want you to take a look at how much space the disc maintains between the top of the joint socket and the top of the condyle. Something fills the space. That's the soft tissue part. I want you to take a look at the shape of the condyle as well. And I also want you to take a look at the shape of the eminence. Particularly, I want you to take a look at the angle of the eminence and get an idea of what normal looks like. So we'll take a look at soft tissue and we'll take a look at hard tissue as well in a normal joint. Now, let's take a look at the soft tissue from an imaging perspective. Soft tissue will look at disc condition. That's what an MRI is going to show. We have an anterior-posterior orientation here. By medical convention, all MRIs will be shot to the left. I don't know why, but that's the way it is. So even if you're looking at a right side of the joint, it'll still look that way. So everything faces to the left. This is a side view, and there's 3 structures that I want you to get comfortable identifying. The first one in yellow that's the joint socket. The second one in red, that's the condyle. And then if you look in between, you should see a bow tie-shaped structure. Everyone got that? That's the disc. I'll take those away again so you can kind of get your eyes trained to what to look for. Joint socket in yellow, above that is brain, below that's joint. Condyle in red, disc in blue. If you look just above the posterior text box, you'll see a circle, that's the ear canal. So that gives you a little bit of orientation. The back wall of the joint socket is the front wall of the ear canal. If you put your finger in your ear and you basically feeling is the back end of the condyle as you open and close. Okay? So that's what a normal anatomy is going to look like from a soft tissue perspective. Here's the front view, and this is the view we don't get trained. As a restorative dentist, I will tell you that's the view that's more important. Because as Frank talked about, that's the view that dictates our vertical dimension. And when we have a loss of vertical dimension, that's typically when we see the occlusal changes that many times present us with challenges that we don't know how to fix. So what that's going to look like is a lateral medial perspective. Lateral is towards the ear, so when you open and close and feel your condyle move, you're feeling the lateral pull. The joint socket's going to be in yellow again. Above that's going to be brain. The disc or the condyle's in red, and then the disc is in blue. Again, and I'll take those away again so you can just get a quick idea of where they are. Joint socket in yellow, condyle in red, disc in blue. So disc condition is one of the first things that we're going to look at. The disc is a fibrocartilage. It's biconcave, so it's self-centering and fits on the condyle, and it's avascular. It's designed to be compressed. So it wouldn't make sense there to have blood vessels running through there because you'd pinch the blood flow. So instead, it gets nutrition from synovial fluid compression. We bite down, synovial fluid is compressed into the soft tissue, we relax, it comes out. So basically, it's pumped in and out of the soft tissue. What that means is, in order for the disc to get nutrition, it needs to be in the right place. We'll take a look at some discs later on that aren't in the right place, and we'll talk about what happens to that. Okay? Ligament attachment, there's a ligament attachment at the lateral pole, the medial pole, as well as the posterior aspect of the condyle. That's how the disc stays attached to the condyle. When we talk about disc position, normal anatomy is typically assumed to be 12 o'clock. That's a little bit of a misnomer. If you really take a look at the literature, the first article was written in 1990, right when MRIs first came out. And it talked about normal joint anatomy being 12 o'clock plus or minus 10 degrees. So really not 12 o'clock, the set in stone standard. 7 years later, another paper was written that talked about 12 o'clock plus or minus 30 degrees. When you have that much of a variation, what do we know? We don't know what normal is. That's really what we know. Today, we've changed our thinking in terms of evaluating disc position. Because ultimately, why do we have a disc? The real reason we have a disc is to help dissipate the load. So the load-bearing portion is really how we should judge what normal is. The normal load-bearing part is the thin part of the bow tie. That should be at about 11 o'clock. If that's the case, it's going to put the posterior attachment at approximately 1 o'clock, which makes more sense because we want that disc to wrap the bone completely, so when we move, the bone is protected at the condyle level and the joint socket level through all different mandibular movements. So think about 1 o'clock as being your normal posterior attachment reference point, and then we'll look at cases that change. So that's the disc position discussion. The purpose of the disc really, as I said, in the adult patient, it protects the joint and it supports normal mandibular movement. If we have a smooth surface that we can open and close against, we don't have any limitations in motion most of the time. We don't have any irritations in movement. Most of the time we have a smooth movement that's coated with lubrication fluid, so it really is a pain-free, stress-free movement. Now in the growing patient, we have a different discussion. Because I'm going to show you a lot of cases today of young kids. In the growing patient, the disc has one primary function, and that's to foster growth to the full genetic potential. Who are the orthodontists in the room? Would you raise your hands again? I think orthodontists today probably have the hardest job because you're seeing so many young patients coming in with joint-based problems that we're not used to picking up, and we're seeing patients that aren't growing well. So many times those cases become more difficult to recognize and more difficult to treat. So we always think of the disc as protecting the bone. Think of it in the growing patient as fostering growth. And again, I showed you George already, the 14-year-old who had a retrognathic mandible that has the airway issue. So many of those young kids have airway issues many times because of a failure to develop normal joint anatomy. So that's the purpose of the disc. But really, I think of the disc as a gasket. I think of it as a 2 millimeter thick gasket. And what it does, it centers the condyle. You know, think of the gasket in your refrigerator. When you open and close the door, you've got that piece of plastic on the side that keeps the cold air in. That's basically what the disc does. It centers the condyle. So we can have a repeatable position to create our restorative dentistry to. And if we have the gasket, the cases become pretty easy. So look at that from a side view and a front view and think three-dimensionally that disc now centers the condyle, so when we close, we can distribute the load that's being placed on the teeth and the joints in a very predictable manner. Okay? That's the soft tissue side. Let's look at the hard tissue side. If we take a look at the hard tissue, we'll look at the bone condition first of all. Here's a CBCT from a side view. Again, you'll see the anterior and posterior designations. We don't have soft tissue here because CBCT only picks up hard tissue. So if you're looking at a CBCT, what are you going to have to do if you're trying to evaluate disc position? You're going to have to guess. And what you're going to do is you're going to take a pencil in your mind's eye and you're going to see if you can draw a normal shaped disc into that space. The cone beam is going to show you the joint socket outlined in yellow. It'll show you the bone outlined in red as well. Here's the CBCT from the front view or the coronal view. We've got the lateral and medial designation. Again, joint socket in yellow, condyle in red. So when we look at condyle position or condition, we're looking to see that the bone has grown normally and formed normally. From a size position, an anterior-posterior dimension should be about 8 millimeters. So the slide on the left, the sagittal view, an easy way to look at that, that bone should fill about 2/3 of the joint socket. If it did, what you can assume is that it grew normally. If it's smaller than that, I'm thinking it's one of those cases that we've talked about where there was early damage to the joint and growth did not occur to the full genetic potential. So that's a real easy way to screen when you're looking at your CBCTs. From a medial lateral perspective, it should be about 20 millimeters side to side. If you do the math, that gives you a surface area of about 160 square millimeters. The reason why that's important is because that's the part that dissipates the load when we bite down. If that becomes smaller, then we start to see issues that become more difficult to manage the bite. Many times those cases have more pain. I'll show you a case later on that has a small condyle, and we'll talk about that a little bit more in depth. We want the bone to be smooth and rounded. We don't want it to be eroded. We don't want it to be jagged. We want it to be protected by the disc. We also want it to be corticated. When you take a look at that, think of the condyle as kind of an M&M, hard outside, soft inside. If the top of that bone becomes broken down, many times that's where we see the issues that start to perplex us in terms of bite changes, in terms of pain. So on a CBCT, I want to see a corticated outline both from a side view and a coronal view. We'll talk about it later in terms of the growing patient and the adult patient in terms of how we talk to patients about that. Condyle position, we want centered in the joint socket. And again, we don't want that to be anterior or posterior. I'm going to show you a lot of cases where the condyle is posterior in the joint socket today. Why do you think that is? When that disc comes forward, we call it an anteriorly displaced disc. It also is a posteriorly displaced condyle. So many times that condyle gets pushed back because the soft tissue comes in front and occupies the space that the disc or that the bone normally would have occupied. In terms of the joint socket itself, the medial aspect is where we have a lot of strong bone. That's the load-bearing portion of the joint. When we bite down, we put a lot of force on the joints, 600, 700, 800 pounds of bite force. The muscles are positioned between the joints and the teeth. Force is going to be distributed between the joints and the teeth. There's no way around it. The force is distributed at the joint level, at the medial aspect, into that bone. So we want a soft tissue protecting it. But that's how the joint socket's designed, again, in a normal joint. So when we put it together, the hard tissue and the soft tissue, then we can talk about vertical dimension of the joint as Frank talked about this morning. If we take a look at the soft tissue and the hard tissue together, we've got a soft tissue vertical dimension of about 2 millimeters. We've got hard tissue vertical dimension of about 65 to 70 millimeters. So that's going to be normal growth. If you take a look at the CBCT on the right side of the screen, you'll see that was pretty symmetrical growth on both condyles. So again, a pretty normal joint. A good thing for us to use as a reference to go back and now compare some of the cases that we're going to see later on today. What's the patient going to tell you who has normal joints? Patient's going to begin pretty much with no clicking and popping, so they're not going to have any joint-based issues as they present with because the anatomy is going to be normal. So you're not going to have patients presenting with clicking and popping. And likely these cases are going to present with little to no pain. Again, most of the time, if the teeth fit together pretty well, they're not going to hurt. These are pretty straightforward patients. They're going to have a normal facial profile. They're not going to have retrognathic mandibles or maxillas in these cases. They'll have a normal opening and closing. They should have a normal range of motion because they don't have any restrictions. There aren't going to be any bite changes because the gasket's in place to position that condyle to allow us to have a repeatable closing position. From the dentist perspective, this is a low-risk case. If I could restrict my practice to all healthy joints, that'd be an easy practice. Problem is that's not the real world. So these are low-risk cases, again, that we can be very confident talking to our patients about the restorative options that they may need. Treatment position can be either maximum intercuspation or fully seated. If you take a look at these two cases, the cases on the top, David doesn't have a lot of wear. He doesn't have a lot applied to his teeth. We could build him in maximum intercuspation. How about John on the bottom? That's a scary case. So in that case, he's proven to us already that he places a lot of load on his teeth. That's a case that I'm going to think probably about trying to use a fully seated position to be able to take advantage of the joint to be able to dissipate some of the load that's being generated. But again, with a case like that, I'm going to tell him that you've already proven that you can damage the best dentistry that we can give you. Anything else is a replacement. But in this situation, I'm going to try and build typically in the joint socket, again, to take advantage of the anatomy. In terms of lateral contact, we're going to do a non-restrictive anterior guidance. A non-restrictive anterior guidance is an anterior guidance where the teeth aren't in the way. Frank talked about pathway wear this morning. That's a good example of teeth being in the way. So we want to make sure that the lower front teeth have enough room to function behind the upper front teeth when they move side to side. Typically, I'll try to generate this through the use of anterior guidance. We'll start on the canines, and I'd like to end up on the centrals to dissipate that load as much as we can. Imaging, there'd be no reason to image this patient. They don't need that because they've got normal joints. Appliance design can be pretty much anything you want. You could do an anterior appliance. You could do a full coverage appliance if this patient requires an appliance. There'd be no indication for surgery in these cases, and ultimately the prognosis is excellent. So those are the cases that you want in your practice. So what I wanted to do is to kind of give you an idea of what normal looks like. From a clinical presentation, I'll show you a case, and then we'll look at that later on in terms of the treatment planning section we talk about at the end. Barb didn't have any pain. She had a stable occlusion. She was a hygiene patient. She called me on a Tuesday morning. She goes, I think I have a little problem with my tooth. So we'll talk about how we talk about our treatment planning cases towards the end of the presentation. So that kind of covers normal joints. Now, let's go ahead and start to take a look at some of the more structurally altered joints, because those are the ones we really need to get a little bit more familiar with. We're going to start with structurally altered at the lateral pole. And when we take a look at this, what we're seeing is we have an anteriorly displaced disc. So the question becomes, how is the disc anteriorly displaced? In most cases, it's a joint injury that causes a ligament damage. It could be a compression trauma where you fall and hit your chin. It could be a stretch trauma where you have wisdom teeth extracted and joints start to click after that. It could be a surgical intubation where patients were open a long time for surgery. It could be something like a whiplash, a car accident, a sporting injury. But anything that can tear a ligament is basically what causes these problems to occur. As I talked to you earlier, I don't think that patients are born this way. I showed you George's case. He had a normal mandible. Something happened to him. He had a bike accident and he fell on his chin when he was about 5, and that's probably what started the process. But most of the time, this is a ligament injury that causes the problem to occur. That can be at the lateral pole and can be at the medial pole. In the tougher cases, it's both that comes off. Again, this relates to a partially herniated disc, a completely herniated disc, and that's kind of the discussion point. So let's go ahead and we'll start with the lateral pole with reduction. What that means is that the lateral pole clicks. With reduction means it clicks. Without reduction means that the disc has changed shape because it hasn't had proper nutrition, and now it doesn't fit the condyle anymore. Let's take a look at the video on this. This is the second video that we'll look at. And when we see this now, we'll open, and we're going to close, and there's the closing click right there. Open, here's the opening click right there. Anyone clicking here? That's what's going on. So that's the opening and closing click. Take a look at the size of the disc in this video compared to the first video. Is the disc smaller or larger? Smaller, isn't it? So, vertical dimension. Has the vertical dimension increased or decreased in this case? Okay. Now, since we're at the lateral pole, the vertical dimension probably isn't affected. That becomes a medial pole discussion. That's why I wanted to bring that point out now in terms of thinking lateral pole and medial pole. This is the case that's the male that's been clicking for 25 years that doesn't have a problem. So it's going to look something like that. What we're going to see, again, with reduction means it's going to click back on. So they're going to open and they're going to pop. The condyle moves under the disc in the opening movements. It's going to look something like this in imaging. The disc is going to be forward in a closed view. And when we open, the condyle is going to reposition under the disc in the open view. Okay? So that's what the imaging will look like. Here's a lateral pole displacement without reduction. And now when you take a look at this one, you're going to see that disc gets folded up in front. What you're seeing now, look at the eminence. What's the difference here now? We're starting to see a flattening of the eminence, aren't we? How's that going to impact your excursive movements? As that moves towards the medial pole, you're going to start to drag on your teeth a little bit more. Again, let's assume this is a lateral pole case. So this is the case where the patient used to click but doesn't anymore, but most of the time they don't have a lot of symptoms. Again, these are the cases that Frank talked about this morning that adapt well, and again, we can do pretty much whatever we need. From a risk profiling, these would be a green-yellow, and again, we'd be fairly confident doing our restorative dentistry on this. But I want you to get a three-dimensional view of what that's going to look like anatomically from a cadaver perspective to get a real good idea. Now, unfortunately, we can't do cadaver studies on everyone, so our next best thing is going to be imaging. What this is going to look like in this case is basically going to look in a closed view, the disc is going to be forward, and in the open view, it's just going to be pushed ahead because it can't fit. So that's what it's going to look like from an imaging perspective. I'm going to lump the lateral pole cases together and talk about those. From the patient's perspective, what they're going to come in with is either a click or a previous click that they used to click and they don't anymore. So that's depending upon whether it reduces or whether it doesn't reduce. Now, again, these cases typically don't have a lot of pain. If they do, it's muscle-based pain, and normally we can get rid of it fairly efficiently through either some type of an appliance or maybe adjusting the occlusion. But again, most of the time these cases are pretty predictable cases to treat. They have a normal facial profile, so we're not seeing any retrognathia or facial asymmetries like we will in the medial pole cases. They have normal opening and closings again, so they generally don't have restrictions in motion. They tend not to have bite changes because the medial pole is still supported with soft tissue, so that's why the designation is the green-yellow as opposed to the yellow-red cases. From the dentist perspective, these are low risk. Again, these are pretty easy cases because we tend to have bite changes, so we can be pretty confident with these. In this situation, again, same as normal joints. You can choose a condylar position in maximum intercuspation if they don't need force distribution, like on the top with Melissa. Melissa was unhappy with her crowns on 8 and 9. The bottom case, Joanne's a little different case. That's a wear case. And in a situation like that, generally I'm going to try and build in a fully seated position again to be able to take advantage of the anatomy of the joints to help dissipate the load that's being distributed in those types of cases. Lateral contact, again, we're going to try and have a non-restrictive anterior guidance. We don't want the front teeth in the way. And again, I'd like to transition over onto the centrals as they move completely through a lateral movement. What that means is your canine and your centrals are going to have the incisal edges about at the same position, so as you come across, you'll be able to pick up on the centrals. If I can get an occlusion like this, most of the time these cases really work out well, and they tend to be very, very stable over a period of time. There's no need to image these cases. Appliance, again, can be either an anterior deprogrammer or full coverage, whichever you're most comfortable with, because we've got the load-bearing part of the condyle protected with disc in these as well. Surgical indications wouldn't be indicated in this, and again, the prognosis is good in these cases because we have coverage at the medial pole, which is the load-bearing part. So a lateral pole case with reduction is going to look something like this. This is Ashley. Ashley was really a neat case for me. She was a great confidence-building case. It was an early case for me. She had joint clicking and she had muscle tenderness. We'll take a look at her case later on when we go over our case studies, because I think it really shows what's possible when we have confidence in terms of joint diagnosis to be able to treat these cases. A lateral pull case without reduction might present with something like Pat. Pat came in, he had worn teeth. His maxillary lateral incisor in number 7 had fractured. That was pulled down orthodontically. He was unhappy with his aesthetics and had a previous left joint. So we know the joint was used to click but didn't anymore. So I'm thinking the disc was off, it changed shape, and now the bone's not able to get back underneath it. Those are the cases that are starting to get a little bit more down the pathway in terms of having more structural change. But again, everything we did in terms of our examination, which we'll go over after the break, pointed us towards a lateral pull case. So we had a good amount of confidence when we were treating this case. And I'll show you the outcome on this case later on this afternoon. Okay, that takes care of the easy cases. Let's move on to the meat of the matter now. We're going to take a look at the medial pull cases. Again, this is the same video. Let's assume that's from the medial pull. And if we look at this video now from the medial pull, what we're starting to think is that now what we're starting to see is a change in vertical dimension. Remember when Frank talked about the case at lunch, before lunch, where those second molars kept fracturing? Perfect example of probably what the joint. As the joint loses vertical dimension, what we tend to do is we tend to hit on our second molars. Do you ever think why second molars wear more, why second molars fracture more, why second molars get loose a lot? It's the tooth that's closest to the hinge that takes the most amount of force. If we were missing the second molars, it would be transferred to the first molar. So really that's the issue. That's why the second molars take the pounding, because they're closest to the hinge, and if we lose the gasket, we lose the holding contact in the joint. We're used to talking about holding contacts in the bite. Think of the disc as the holding contact in the joint, because that's really what it is. That's what maintains the dimension in the joints. When we close, we have a position that we can build to. If the gasket isn't there, then we have wobble at the back end of the system. If you have wobble at the back end of the system, you're going to have wobble at the front end of the system. It's all one piece. We've kind of got brain dead into thinking that it's either the front or the back, the right or the left. We need to let that go. It's all one piece that has to fit against the base of the skull to be able to close and have our occlusion managed. So that's really, when I think about occlusion, I don't think teeth or joints, I think lower jaw to upper jaw. And that's how we need to be able to work the system, okay? In this situation, a medial pole displacement with reduction is a case where we're going to have clicking at the medial pole. The condyle is going to move under the disc in the opening movements. And again, same type of imaging that we looked at with the lateral pole. So it gives us an idea of what it'll look like with imaging. A medial pole case without reduction, again, is the situation now where we take a look at the video, and assuming this is a medial pole, now we start to see the flat eminence. When we start to see the flattened eminence, think about back tooth separation. How do back teeth separate? Two ways: anterior guidance and condylar guidance. As we shallow each of those, the back teeth start to drag against each other a little bit more. For the most part, in my experience, as Frank said, I like to have the teeth protected by the canines if we're able to establish that type of an occlusion. Over the years of practice, the cases that have had more issues in my hands have been the ones where the back teeth are grinding against each other. I'm more likely to have that occur if I've got a medial pole case, especially without reduction, because that's typically a more long-standing case. So medial pole cases are going to start to present a little differently. Without reduction means the condyle's not going to move under the disc, and again, it's going to look something like this in terms of imaging. Now, when we talk about that, we're going to move on to the next type of joints, which are in the yellow-red category as well, and those are the perforated cases. When we talked about the medial pole cases, we still have ligament attaching that the condyle was functioning against when they moved. In this stage, this is a more of a long-standing issue where now the bone has gone all the way through the soft tissue and it's in direct contact with the skull base. So now when we take a look at these, we see a really different video than we did from the first one. Can you locate the disc? It's the little ball right in front of the condyle. The disc is basically dried out. Okay? Now take a look at the joint socket. How flat is the joint socket? It's really flat, isn't it? So again, your back teeth are going to have a hard time separating. But here's the question I want you to answer. I want you to take a pencil in your mind's eye, and I want you to draw in how much bone you would have to draw to build that back to normal. And then I want you to do the same thing with the soft tissue. So how much bone, how much hard tissue do we have to add back to get to a normal contour for that condyle? Any thoughts? 2-3 millimeters? More? 5? More? I bet you this is 6, 7, 8 millimeters of bone. We throw in 2 millimeters of soft tissue, we're probably into double digits on this case. When we talk about vertical dimension, we think about it at the tooth level. How confident would you be opening a bite 10 millimeters? Not very. And yet, we lose vertical dimension in double digits far more often than we think. Go back to George's case, the first one I showed you. How much bone loss do you think he had? He had at least 10 millimeters of bone loss. I want you to change your thinking about vertical dimension from the teeth to the joints, because we lose more vertical dimension at the joint level than typically we will ever lose at the tooth level. The teeth reflect it, but that's the genesis of the problem when you look at something like this. Now, these patients can either be painful or actually these patients can be very stable. By the time the disc is out of the way, by the time the bone has hardened, you can do a lot of restorative dentistry on these cases with a very predictable outcome. So I don't want you to think that these cases you can't do restorative dentistry on. I just want us to know what we're working on before we start the case. Because the old saying is, before is an explanation, after is an excuse. I used to give excuses before I imaged a lot more. Once I started imaging and starting understanding the back end of the system as well as I did the front end of the system, it really became a different discussion. And dentistry, honestly, became a lot more fun. So, in these types of situations, as we said, the soft tissue perforates. There's direct contact between the condyle and the joint socket when we've got the perforated cases. It's going to look something like that in terms of imaging, not an uncommon image to see. Again, that matches us almost exactly with the CBCT matches almost exactly with the video. So it kind of gives you an idea of what you'll see in those types of cases. So from the patient's perspective, how are the yellow-red cases going to present? Whether it's a medial pole with reduction, a medial pole without reduction, a perforated acute, or a perforated chronic case. They're going to present with a click, a previous click, or they're going to have audible noise if they're a perforated case. If you can hear the noise when the patient opens and closes without having to use a stethoscope or a Doppler, they're probably perforated. So again, when you start to hear those auditory sounds coming from joints, when you start to listen, you'll get an idea of where they're at. Now, these are going to have variable pain levels. We take a look at this case. This is a really interesting case. Frank talked about muscle pain this morning, and we see a lot of patients with muscle pain. I thought what Frank said today was really dead on in terms of we thought that we understood occlusion, and we thought that if we got the bite right, the muscles would calm down. I don't believe that anymore. I'm going to talk to you a little bit later on about why I think muscles start to fire, and Frank talked about it this morning. It's a sympathetic nervous system. That's really, I think, going to be the in pain management, is understanding the sympathetic nervous system. But let's take a look at this case. When you take a look at this case, this is Michael. Michael's 14 years old. What do you notice when looking at his ramus lengths? Remember we talked about normal ramus length should be 65 to 75? On the right side, he's 66.13. On the left side, he's exactly 11 millimeters shorter, 55.13. So what I'm assuming is his left joint was injured first, but let's take a look at his bite. Now when you take a look at his bite, look at the midlines. Kind of a similar case to Tracy's, as I showed you, that had the midline deviation to the left. Same type of thing. The mandible's going to deviate to the side with the shorter vertical dimension. That's why you see things start to shift to the left when you have a ramus discrepancy that looks like that. Does that make sense? Okay. Now, part of the issue is, in order to evaluate the bite, as we saw in Tracy, I don't think we can do it in maximum intercuspation because the lateral pterygoid is going to pull the mandible forward to get the teeth to fit, and we lose the ability to recognize the problem. That's the issue. So I'm going to suggest that we start thinking about during our evaluations of the bite or the occlusion in a fully seated condylar position so we can pick that up. But in this case, how much does the lateral pterygoid have to contract to get things to fit together? A lot. This was one of the big slides that Frank talked about before lunch that said maybe this is a joint-based issue. Now we have confirmation through imaging that it's a joint-based issue, and we understand why muscles get sore, because how much does the muscle have to contract to move that mandible to get the teeth to fit? That's a big slide. That muscle's going to get sore. That's more than a 0.5 millimeter or 1 millimeter slide. So that muscle's going to have to work a lot to get things to fit together. So we'll see variable pain levels. Sometimes we'll see really hot muscles in these cases because they have to work so much to get things to function. We also can see pain coming from herniated discs. As we take a look at this case, we see a large herniated disc sitting right in front of the bone. It's at about at the 11 o'clock position. Remember I talked to you earlier about anteriorly displaced discs and posteriorly displaced condyles? This is a perfect example of it. When you take a look at the condyle, where's the condyle? Condyle's in the back of the joint socket, isn't it? Where do you think the lower incisal edge is going to be in this case? It's going to be back too, isn't it? Remember, it's all one piece. If that condyle comes back, the lower anterior teeth are going to come back as well. What kind of occlusion is that patient going to present with? More of a class 2 patient, exactly. That's why I said the orthodontists today have the hardest job in dentistry, because there's all types of these cases out there. So, herniated discs really come down to two questions. Is the disc impinging on any structures? Is it displacing any anatomic structures? Well, here it's displacing the condyle, and again, it's impinging on the space that the condyle would normally occupy. So when we start to take a look at pain levels, I want you to be aware that we have to know today that it's more than just muscle, because that's what we were taught. We were taught that when patients hurt, primarily it's muscle. And if we get the bite to fit together evenly, the pain's going to go away. You know, I learned that the hard way. That's not true. All those splints I showed you on the picture that I showed you with Lisa and I golfing, I'll show you that case, like I said, in a little bit. You'll see why they didn't get better. It wasn't because of the splint. It was because of the joint. So we can see pain from herniated discs. We can also see pain from bone. There's three main types of bone pain that we see. We see small bone. If you take a look at this case, what do you notice right away? Does this pass the 2/3 test? No. So I'm thinking that this joint probably was injured early in life, before growth was able to occur fully. This patient's 17 years old. Again, what do you tell the mom and dad? What do you think her bite looks like? She's an anterior open bite case because she's lost so much vertical dimension. She tells me that her bite feels like it's changing. The bone isn't stable enough to be able to support the load that's being applied to it. Basically, when you look at a case like this, it's kind of like walking through wet grass with high-heel shoes. So I've been told. But really, that's what we have to think about in terms of bite stability. When you've got small bone like that, that becomes a different discussion in terms of the prognosis with the parents. And those hurt because it can get overloaded. How about this case? This is Kim. She's 43 years old. She's got eroded bone. If that was a knee, what do you think the discussion would be? It would be more than not chew gum and get physical therapy. But generally, that's what we tell patients with eroded bone. And the last is edematous bone. We usually think about bone changes occurring on the outside of the condyle. They can occur on the inside of the condyle too. I'll show you this case later on and how that bone started to swell on the inside. But basically, think of that like a pulp. It's a hyperemic situation, very similar to marrow space and pulp. They both can swell, they're both vascular, they both can hurt. No difference. So pain can come from muscle, pain can come from disc, pain can come from bone, pain can come from upper cervical. I'm amazed at how many people have upper cervical issues when I take CBCTs. If you take a look at this case, this is Megan. Megan's 32 years old. Megan presented with a lot of pain in the back of her head, over the top of her head. Here's an easy take-home to remember. Patients present with pain like this, think joints. Patient presents with pain like this, think neck. Now, that's a broad brush and it's not always accurate, but it's a pretty good guideline to be thinking about. You can see how that upper cervical vertebrae is rotated to the right. And now all of a sudden it starts to give us an idea of that maybe there's other issues besides the joint in this case. Because I can make the best splint in the world for her. Perfectly balanced, perfect guidance, even contact. And yet she may not get better if it's not a joint-based problem, if it's a neck-based problem. I'll show you a little bit later after the break how we differentiate between those. Okay? We also see degeneration of the upper cervical spine commonly on CBCT. If you take a look at that case, look at the bone starting to fill in between the vertebrae. Look at the straight neck. That's kind of the military neck that you'll see people who present like this when they walk in your office. If you say hello and they can't turn their neck, I'm starting to think that maybe there's an upper cervical issue that we need to be clued into as well. So when we think about pain, don't forget about the other sources of pain besides muscle. Lastly, the pain, so from a patient's perspective, what they're going to hear, they're going to present with jaw locking and difficulty opening easily. We take a look at this video of Margaret. Margaret has a joint-based issue, and you've seen this patient a million times in your practice. She has to deviate to open. What's happening is when she's coming forward, she has to move around that disc to be able to get things to open. So that's why you're seeing the problems typically in those types of cases. There's something in the way. And typically it's the disc when they're trying to open and move. So in that situation, it's almost like you're going down a sled down a hill and there's a big boulder in the way. You got to get around it. Think of that in terms of why the condyle has to deviate when they're opening. They'll have aesthetic concerns as well many times, these cases. Many times the aesthetic concerns are due to a change or to obtain normal vertical dimension. Take a look at the facial asymmetry in Deanna. If you take a look, she deviates to the left. You can see that in the surface rendering of her CBCT. Basically, this is a facial deformity. This isn't simply a clicking joint. This is a facial deformity on her. When we take a look at the CBCT, this is the same CBCT view that I showed you on Tracy. I like this view because it gives us a chance to see both condyles. Take a look again at the condyle and take a look at the maxilla as well. The maxilla didn't grow either. So many times these patients are the ones that present with sleep-based issues or airway breathing issues because there's a lack of growth of not only the mandible but the maxilla as well. Take a look at the right side. You think the right disc is in the correct position? No. Is that right disc herniated to the lateral aspect or the medial aspect? Look where the space is. the disc will be where the space is. So the lateral is towards the R on the screen, the medial is towards the middle. So I'm suspecting that that disc herniated towards the medial aspect of the right joint. Because again, that left side, we've got or on the lateral aspect, we've got a compressed joint space. The left joint never grew. That's the problem. You can see it's smaller bone. She's had some proliferative bone on the lateral aspect of that left condyle, but that's basically the issue. That joint just never grew. So we see aesthetic concerns in terms of facial asymmetries on a regular basis. One of the things I'll do, the first thing when I look at a patient, I'm looking at their chin. Is the chin in the middle of their face? When you lie them back in the chair, you can look down and look right to see which way the chin's deviated. It's an easy screening tool when you sit the patient to be able to get an idea of what you have to be looking at and starting to talk about when you're talking to them about their clinical findings. We also see retrognathia. If you take a look at Megan, she's retrognathia maxilla and the mandible. Flores Muir talked about that probably 10, 15 years ago in the Ortho Journal, the disc abnormalities associated with reduced forward growth of both the maxilla and the mandible. Again, don't think joints influence just the mandible. They influence the maxilla as well. And when you take a look at her imaging, here's what it looks like. 14 years old. Pretty bad joints for a 14-year-old. Again, you can see the wear on the top joint. Pretty displaced disc. Both discs are severely degenerated. The discs aren't coming back. That disc is off for good. So she's the rest of her life without a disc. And what we're hoping is that we can manage her bite. But not only her bite, her airway, her aesthetics, her pain, the whole ball of wax gets tied up in these cases early. The earlier we can recognize these, the better they are. Young kids shouldn't snore and young kids shouldn't click. That's the take-home, that if they do either of those, that should warrant further investigation, okay? So uneven or relapse bites we'll see in these. This is the patient that will present with their bite that's changing. Take a look at Eve. Eve is 12 years old. You know, interesting case. Take a look at her central incisors, upper central incisors. Are they coming out at a normal inclination? No, they're retroclined, aren't they? So let's think about that. What do we many times say distalizes condyles? We say the teeth do, don't we? We say they've got a trapped mandible because the maxilla is there. I like this case because I think it goes the other way. I think the mandible doesn't grow and then those teeth collapse in to fill the space. That's exactly what's happening in her case. So when you take a look at her imaging at a 12-year-old, she didn't lose vertical dimension, she failed to achieve it. So when we say we lose vertical dimension, really what we should say is we either lose vertical dimension or we fail to achieve normal vertical dimension. And that's what happens in her case as well. When you take a look at her imaging, here's what she looks like. When you take a look, she's got small bone. She doesn't fill the 2/3 rule, so we know it happened early. She's got a disc that's not in very good position either. We'll talk about this case. This is one of the treatment planning cases we'll look at later on this afternoon. But you can see the right and the left joint are pretty compromised in both of those. Now we can see adult. Here's Angie. This is a degeneration of vertical dimension or a failure to maintain. The uncoupled bite is what Frank was talking about before lunch. And if you take a look at the left side of the right side of the screen, you'll see the pink bite record. We'll take that when we take our photographs to be able to index the mandible and the maxilla in a seated position so we can evaluate space. As Frank said, the larger the slide, the more concerned I am that I've lost the gasket. So here's the take-home. How thick is the disc we talked about? About 2 millimeters. So if I have a shift that's greater than 2 millimeters, I'm starting to think that I may need to take a closer look at the joints. Does that make sense? So really, that's the take-home, is that if we have a slide that's greater than 2 millimeters, our risk profiling goes up. And those are the cases we may want to talk to the patient about getting additional information so we know what's happening at the back end of the system as well. Here's what her imaging looks like. Pretty damaged joints. Now, her history, if you just took her history alone, you'd be able to diagnose the case. She's 62 years old. She's had 5 occlusal appliances since she's been 21 years old. She's got pain issues. She's got pain on the side of her head. She's got pain on the front and back of her head, so I'm thinking neck as well. She has a lot of stuff that's been going on. So again, you can see the breakdown that's occurred in her, but basically when we see changes in occlusion, think 2 things: a failure to achieve normal vertical dimension, which is a developmental issue, or a degenerative issue, which is failure to maintain vertical dimension. Okay? So the patient's going to present with uneven bites or relapse bites, or however they want to describe it, but a bite that's not stable. Now, what are we going to think about these cases from the dentist's perspective? These are high-risk cases. These are the cases that I want to understand the anatomy that I'm working with. You know, it's interesting. I was lecturing at the summit 3 years ago, and I had a woman come up to me. She said, "I'm really afraid of treating TMJ cases." And I said, "I understand." I said, it would be similar as if a patient walked into your office with a large carious lesion around a big amalgam on number 14. Patient had a lot of pain. What would be the first thing you would do? You'd take an x-ray basically to assess the anatomy, right? Well, what if your x-ray machine was broken that day and you couldn't take an x-ray? Would you want to start the endo? No. But what we have done in dentistry is we feel confident in joint-based cases without knowing the anatomy. It doesn't make any sense. If you really think about it, when we put an appliance in, and Frank's going to talk about appliances tomorrow morning, what does an appliance do? An appliance basically is going to change the load distribution. That's what an appliance is going to do, regardless of what type of an appliance it is. Whether it's an anterior deprogrammer, whether it's a full coverage appliance, whether it's an anterior repositioning appliance, whether it's a posterior galb appliance, it doesn't matter what the appliance is. What the appliance is going to do is to change the load in the system between the teeth and the joints. The problem is many times we don't know the condition of the anatomy at the joint level that we're changing the load on. The splint that I showed you on the golf picture at the beginning of the lecture, I put that in a joint that had, I put those splints in a joint that had bad anatomy. That's why the pain is not better. We always think of splints as reversible treatment because we've been taught that most of the pain comes from muscle. If it's a muscle-based problem, sure, it's reversible treatment. If it's not a muscle-based problem, if it's a disc problem, if it's a bone problem, whether it's small bone, eroded bone, edematous bone, those cases may not respond well to splints. In fact, they may respond just the opposite and get worse. So in terms of having confidence with our patients, really one of the things that we want to think about is understanding the anatomy when we're going to be treating those cases that we're changing the load factors on. These cases are a really good example of why high-risk cases with structurally altered tissue, it's really nice to be able to understand the anatomy in terms of what you're working on. These patients are probably going to present with pain-based issues, as Angie did as well, and many times they'll have bite instability. Those are the 2 biggest things I see. Something hurts or something doesn't fit. Those are the 2 biggest things that we see in the yellow-red cases. So with those types of cases, when you have those come into your practice, think about taking a look at the anatomy at the back end of the system. Where are you going to build these cases? A lot of times that's going to depend upon what's happening at the joint level. Let's take a look at this. This is the same patient. This patient's name is George, another George, and I want you to take a look at these 2 MRIs. One is in a fully seated position, and the second is in maximum intercuspation. Now, I was really heavily trained in centric relation. So when I was a young dentist, I treated pretty much everyone in centric relation, or a fully seated position, however you want to say it. If you take a look at this MRI, what's the more stable position? Is the disc covering the bone more in fully seated or in MIP? MIP, isn't it? If I had that to do over again, I would treat that in MIP. I'm going to step away while the bolt of lightning hits. But we always made it about muscle, because what was the advantage of working in centric relation? We were able to shut off the lateral pterygoid. And since we believed that most pain was muscle-based, we thought if we could get to centric, harmonize the bite in centric relation so the lateral pterygoid wouldn't have to contract and cause pain, we could be home free. That's not the real world. All those concepts were developed based upon our understanding of joints from the textbook drawings that I showed you earlier. When we look at imaging, it doesn't support that. That's why Frank says we've changed our thinking over the years based upon what we know today. So in this case, if I can get an idea of if either position, whether it's fully seated or MI, offers me a better condyle disc interface, I'm going to use that. And in that situation, I'm going to build an MIP as opposed to fully seated. I would rather try to protect the joint than protect the muscle. That's been a major change in my thinking. Because again, I was trained very traditionally in terms of centric relation to be able to make sure that I could seat the condyles. Today, I would look at it differently. Okay? So treatment position is going to be based on imaging in these types of cases. How about your anterior guidance? I'm going to break another rule today because with anterior guidance in these cases, I'm going to think about spreading it onto the posterior teeth a little bit as well. When you've got anterior guidance and you can put it on the canines or any type of anterior teeth, what's it going to do? It's basically going to seat the joints, really. That's one of the advantages of it, because if you have an intact disc and you can seat against that strong bone that I showed you, no problem. This is a great case to look at because this case is basically flat. There's been significant bone change over this case. Actually, this patient, interesting case, this patient was equilibrated 17 times. Why?